Good morning, everyone. I just want to say, as a 54-year-old woman, I'm glad to know that my genital tract is still dynamic. I was a bit worried about that. So, my name is Charlotte Redding. I'm one of the co-chairs with Trevor Hart and Angela Kaida for the social science track. It gives me great pleasure to welcome our friend and colleague, Dr. Clive Aspen, to the land of the Coast Salish people, and to introduce him to all of you. Dr. Aspen is Maori. He is of the Ngati Maru people of Aotearoa. My Maori is very bad. Please excuse me. Clive has dedicated his life and his work, as many of us have, to improving the health of Indigenous people. He's done that most recently as a Senior Indigenous Research Fellow at the Poach Centre for Indigenous Health at the University of Sydney, as the Research Director of the Menzies Centre for Health Policy, the Executive Research Officer of New Zealand's Maori Centre of Excellence, and the lead investigator for New Zealand on a tripartite Indigenous research program that was funded through CIHR, as well as the Australian and New Zealand counterparts. He was also the founding editor of an international peer-reviewed journal called Alternative, a journal for Indigenous scholars. What he's most internationally known for, though, is his work in the area of HIV among Indigenous peoples. He was a founding member of the International Indigenous Working Group on HIV and AIDS, which is hosted by my friends at the Canadian Aboriginal AIDS Network. So, Clive, you know, I've been waiting for this for a long time, and I am deeply honored that you have accepted the invitation to come all this way to speak to us. And I would like everyone to join me in saying, Kia ora, no mai haere mai ki Turtle Island. Clive Aspen.
A tēnā koutou katoa. Ko tēnei te mihi atu ki a koutou, ko haere mai nei ki tēnei hui. Ki ngā tangata whenua o tēnei whenua, te iwi o Coast Salish, ka tino nui taku mihi ki a koutou katoa. Ki tō tātou tupuna, ko haere atu ki tō tātou kāinga tuturu, haere, haere nā mate haere. Kia koutou katoa kua haere mai nei I tēnei rā, tēnā koutou, tēnā koutou, tēnā koutou katoa. Bonjour tout le monde. Je viens de vous parler dans une des langues officielles de la Nouvelle-Zélande, la langue maori. Et pour vous traduire, je viens de dire merci et j'ai salué les gens indigènes de cette région, les gens Coast Salish. J'ai salué aussi les ancêtres, les gens qui sont allés devant nous et avant nous. Et je les ai remerciés de m'avoir accueilli et de m'avoir permis de vous parler à cette réunion, à cette conférence aujourd'hui. Je peux vous dire que c'est vraiment un très grand honneur et un très grand privilège de pouvoir parler devant vous ce matin. And for the English speakers in the room, I would like to say that I am extremely honored to be here this morning. I want to begin by acknowledging the Indigenous people of British Columbia, and in particular I want to acknowledge the people of the Coast Salish Territory, the people on whose land we are meeting this morning. And I would like to thank them for welcoming me here today. I want also to acknowledge all the Indigenous people of Canada, the First Nations people, Inuit and Métis people. I want to acknowledge your ancestors. I want to acknowledge your struggles. But most of all, I acknowledge your resilience and the resilience of all Indigenous people around the world, who, despite hundreds of years of colonisation, continue to thrive in the face of ongoing oppression, dispossession and marginalisation. Today I'm going to be using the word Indigenous to describe diverse peoples from all around the world. They include the Aboriginal people of Canada, the Aboriginal and Torres Strait Islander people of Australia, and the Māori peoples of New Zealand. I would like to thank the organisers of this conference for inviting me to speak to you today. I feel very honoured, I feel very privileged to be given this opportunity to speak to this esteemed audience. Thank you very much. And thank you, Charlotte, for your very warm welcome. I speak to you today as a Māori researcher who has lived throughout the entirety of the AIDS epidemic. Like many people here today, I've lost my fair share of friends to HIV, and I'd like to honour them and their contribution to our communities and families. I lived in Paris, France during the early 1980s when men were being infected by HIV and didn't even know it. And when infection rates were much higher than they should have been because of the contaminated blood from prisoners that was being used for blood transfusions. I visited New York City in 1983 and I scarcely dared to shake hands with people, let alone have sex with them. Even though the city was awash with health promotion brochures that explained how to have sex in the midst of an epidemic, a rather novel concept for gay men in the early years of the AIDS epidemic. And when I returned to live in New Zealand in 1984, I was convinced I had somehow contracted this mystery disease when I felt a swelling in my neck. I took myself off to a doctor who told me I needn't worry, since there would be a cure in 10 years' time. And here we are 30 years later, more than 30 years later, and there is still no cure. In the early days of the epidemic, people used to describe the most affected groups as the 4 H's: homos, heroin users, Haitians, and whores or hookers. Well, I'm here today to tell you that it's high time we added the next letter in the alphabet, the letter I for Indigenous. In fact, it's way overdue. Like many Indigenous people, I grew up surrounded by images like this one here that you see before you, and they provide salient reminders that we are descended from a long line of illustrious ancestors. Today, these images adorn the houses where we meet, and they serve to remind us of who we are and where we have come from. But most importantly, they remind us of our responsibilities to future generations and the role that we can play in ensuring the survival of Indigenous communities into the future. As a child, I grew up surrounded by loving parents, aunts and uncles, and grandmothers. My siblings and I always knew that we were Māori, but the one overriding message I received from my mother and from her mother was that I should never marry a Māori. There was great shame about being Māori, and the best thing I could do was to put it all behind me and pursue success in the Pākehā or white man's world. If you look closely at my grandmother, the woman in the middle on the right, you can see that she has only one functioning eye. She lost the use of one of them when she looked at an eclipse as a young girl, and for me this is an example of what can happen when people are not given the information that they need about how to protect themselves. one of the key concepts in our efforts to prevent the transmission of HIV, and one of the messages of my talk today. This is our meeting house, and it's not unlike the longhouses I've seen here in Canada. Like these, they are richly adorned with images of ancestors. And this is the modern-day Māori family to which I belong. As you can see, we represent Indigenous people in the 21st century. We come in all shades, sizes, and colours, ranging from dark as to lily white. And if you look closely in the back row of that photo, you can see the evidence that I took my mother and my grandmother seriously about not marrying a Māori. This is me and my partner Terry, who is a sixth-generation Australian. I've been coming to Canada for almost 10 years now, and I just want to acknowledge the tremendous work that friends and colleagues are doing in the area of HIV. I'd like to thank you all for your work, but especially for the tremendous support that you have shown me in the time that I've been coming here. I want to pause to acknowledge the tremendous work done by people like Laverne Manette, who very sadly passed on World AIDS Day just over 2 years ago. Laverne was a true leader in the world of Indigenous people and HIV. I first met Laverne when she convened the International Indigenous People Satellite meeting that preceded the International AIDS Conference in Toronto in 2006. Through her tenacity, she ensured that Indigenous people had their fair share of the program, and thanks to her efforts, we have seen an increased profile of Indigenous people and presentations at international AIDS meetings. Laverne is just one of the many Indigenous activists who have worked hard to ensure that the needs of Indigenous people affected by HIV are recognised and addressed. And I would like to acknowledge the work done by Indigenous peoples here in Canada, but also in other parts of the world, especially in those countries where Indigenous peoples suffer from significant HIV disparities. So today I'm going to talk to you about these HIV disparities. I'm going to begin by looking briefly at some of the health disparities that confront Indigenous peoples today. I'm going to draw on examples from 3 countries in particular: Australia, where I live, New Zealand, where I was born, and Canada, which is my second home. These countries have had similar experiences of colonisation, and it is this negative impact that has led to parallel situations across the 3 countries. Since the early days of the HIV epidemic, Indigenous peoples were identified as vulnerable to HIV. So I'm going to look at some of the warnings about vulnerability, and I'm going to pose the question: what, if anything, have we learned from these past experiences? I'm going to draw your attention to some really innovative community-based initiatives, and I'm going to conclude with a discussion of how these initiatives have made a real difference in the short time that they have been operating. In fact, it is these community-based initiatives, I believe, which offer our best hope of overcoming the high rates of HIV among Indigenous populations. Finally, I'm going to finish by identifying what needs to happen now and urgently if we are really going to have an impact on HIV rates among Indigenous populations, and what we will all need to do in order to make that happen. So, who are Indigenous people? Well, today they number almost 400 million, and they live in almost every part, in every part of the world. Indigenous people are characterised by removal from land. Many of us have been relocated to live in places that are not our own. Indigenous people have very high rates of incarceration. In New Zealand, the Māori people number 15% of the population, yet they make up 50% of the prison population. In Australia, Indigenous people make up about 2.5% of the population, yet they make up almost 20% of the prison population, and I suspect that those figures are mirrored here in Canada. Indigenous people in the 3 countries which I'm talking about have been institutionalised. We have been ravaged by the introduction of diseases. HIV is just one of the many epidemics that have decimated Indigenous peoples. We've been we've lived under the imposition of colonial laws and Western religion, and these have led to the suppression of Indigenous knowledge, including our languages and our customary practices. And overall, this has led to the disruption of traditional social structures. Like many Indigenous peoples, I grew up with constant daily reminders of the devastation caused by the impact of colonisation. This is my ancestral land of Hauraki, with our sacred river Waiho running through it. In the distance, you can see a few stands of trees. This land was once covered in tall kahikatea, trees such as these. When Captain Cook sailed up this river in the late 18th century, he determined that these trees would make ideal masts for the British Navy, and he subsequently had the trees felled and transported to England. Unfortunately, the trees rotted before they got there, and we were left with land that has suffered badly from environmental degradation and poor drainage, a common pattern of destruction to that which has occurred in many parts of the world, including this country. I'm mindful also that the Indigenous people of Canada live with similar constant reminders of colonial dispossession. I want now to consider health disparities, vulnerability and HIV rates among the Indigenous peoples of Australia, New Zealand and Canada. And I'm going to draw on observations from each of these countries to illustrate the points I want to make. While I use a particular country as an example, I need to point out that these three issues, health disparities, vulnerability and HIV disparities, apply to all three countries. I've chosen three very simple slides to make the point that Indigenous peoples are at distinct disadvantage throughout their whole life cycle. From before birth to the end of their lives, Indigenous peoples suffer significant disadvantage, with this contributing to significant health and social disparities. This graph shows the rates of low birth rate weights in Australia, with the Aboriginal and Torres Strait Islander population having much greater rates of low birth weight than other Australians. And as you're aware and as you know, these have repercussions throughout the rest of one's life. The disparities in life expectancy in Australia are staggering, with Indigenous Australians living on average 10 years less than everybody else. In some parts of the country, the gap in life expectancy is as high as 20 years. And even at the end of their lives, Aboriginal and Torres Strait Islander people suffer significant disparities. Rates of end-stage kidney disease, for example, are very high among Aboriginal and Torres Strait Islander people as a result of remoteness and poor access to health services, and this can lead to dislocation from communities and families. As you can see, the rates of end-stage kidney disease are over 5 times higher for Aboriginal Torres Strait Islander people than they are for non-Indigenous Australians. From the very early days of the HIV epidemic, there have been warnings that Indigenous peoples were vulnerable to HIV. Using New Zealand this time, my country of birth, as an example, let's see how this was articulated in the 1990s, just over 20 years ago. In 1994, the Ministry of Māori Development in New Zealand issued this report. It contained this statement: "It appears that Māori may possibly be at greater risk of HIV/AIDS than other groups in our society. It is possible that the epidemiological pattern among Māori could change from a homosexually transmitted disease to a slow but extensive heterosexually transmitted epidemic. Health promotion strategies for Māori must take this possibility into account." The report goes on to identify the factors that make Indigenous peoples vulnerable to HIV. In this case, they apply to Māori, but they apply to other Indigenous peoples as well. Youthful age structure, youth unemployment, relative poverty, overcrowding, poor housing, youth alienation, early school age, leaving age, powerlessness, low self-esteem, loss of cultural identity, Trans-Tasman migration, that applies only to us because of the fact that Australia and New Zealand are on both sides of the Tasman, but migration has been identified as a factor in other parts of the world. Imprisonment, drug use, lack of information, lack of access to culturally appropriate services, high prevalence of sexually transmitted diseases, poor health literacy, poor access to health resources, and in particular, condoms. Now let's turn to Canada and consider the position of the First Nations, Inuit, and Métis people. Well, let's fast forward 15 years from 1994 to 2009. This is a statement from another government document, this time the Canadian government. The vulnerability of Indigenous peoples continues to be a major theme, and this time it refers to all Indigenous people around the world. I attended this meeting and I remember clearly that there were representatives from many countries, all of whom said that the communities from which they came had been adversely affected by HIV. The report says the relationship between HIV and Indigenous peoples has not received due international attention, despite the fact that Indigenous peoples have particular vulnerabilities to acquiring HIV. And the report also identifies these particular trends: a higher proportion of new HIV diagnoses among Indigenous peoples, high rates of HIV transmission by injecting drug use in developed countries. Men who have sex with men are the most common mode of transmission in most developed countries. High rates of HIV transmission among Indigenous women, particularly in developing countries. And a younger age of HIV infection of Indigenous peoples compared to the non-Indigenous populations in some countries. And these are the risk factors that this report identified: lack of political and social power, fragmentation of family and community relationships, gender inequalities, socioeconomic disadvantage including poverty, lower education standards and low health literacy, cultural and language diversity, dispersion and remote location, which limit HIV prevention and access to services, stigma and discrimination relating to race, sexuality and HIV status, and a younger and more mobile population than non-Indigenous people. So, when we look at a table like this, the obvious question that springs to mind is really, what notice, if any, have governments, health services and funders been paying to these warnings about vulnerability that people have been talking about since the early 1990s? And if I could answer that question myself, I'd have to say they've been paying very little attention. And going on these data from the surveillance agencies in Australia, Canada and New Zealand, it would seem that little notice has been given to the vulnerability of Indigenous peoples, not only here in Canada, but also in Australia and in my country, New Zealand. This table shows the standardised rates of HIV diagnoses among Indigenous populations in the three countries from 2004 to 2008. And if we look closely at what's going on in Canada, we can see that the rates among Indigenous males and females is almost 200 cases per 100,000, as compared with 50 for non-Indigenous men and just under 10 for non-Indigenous females. In Australia, there are significant disparities between Indigenous and non-Indigenous females. And in New Zealand, there is a slight difference between the rates of diagnoses for Māori and non-Māori females, but these numbers are small, so it's not possible to make any hard and fast conclusions about what is really happening. But we do know from another analysis of these same data that the National Data Collection Agency, the AIDS Epidemiology Group, has been putting together that Māori men are more likely than non-Māori men to test late for HIV, and as you know, this is likely to lead to poorer long-term health outcomes. This slide shows information from the most recent status report issued by the Public Health Agency of Canada in 2010. I understand from speaking yesterday to an official from PHAC that the 2008 figure has actually risen to 9%. And it is this, and if we look quickly at these bullet points, we're told that the Canadian population of Aboriginal peoples is equal to 3.8%. They're growing faster, they're more youthful, and they have poorer health than the rest of the population. That figure of 8% of those living with HIV and AIDS in 2008 has risen now to 9%, and they make up 12.5% of all new infections. Aboriginal peoples in Canada are diagnosed at a younger age than other people. They have a higher proportion of Aboriginal women who are affected. Injection drug use, heterosexual contact, and men who have sex with men are the main vectors for the transmission of HIV, and social determinants of health increase people's vulnerability to HIV. HIV-related stigma, sexual violence, racism, the effects of colonialism, and residential schools are major factors that impact on these high rates of HIV. Population-specific research and evaluation needs to happen, and culturally specific efforts in preventing the transmission and acquisition of HIV and improving the quality of life of Aboriginal people living with HIV and AIDS are required to successfully address the epidemic in this population. And it's that last bullet point that I think is most significant and most important. So let's now turn to the community-based initiatives, which, as I said earlier, provide our best hope of overcoming the impact of HIV in Indigenous communities and, over time, of preventing further transmission of HIV among Indigenous peoples. I'm going to refer to community-based organisations in Australia, the Anukunna National Aboriginal and Torres Strait Islander HIV/AIDS Alliance; in Canada, CAHR, the Canadian Aboriginal AIDS Network; in New Zealand, INA, the Māori Indigenous and Pacific Islands HIV/AIDS Foundation; an international organisation of which I'm a member, the International Indigenous Working Group on HIV and AIDS; and the Toronto Charter. I'm going to tell you a little bit about the Toronto Charter, which is an Indigenous Peoples Action Plan on HIV and AIDS. So in 2006, the Toronto Charter was launched at the International AIDS Conference. And at this point, I'd just like to do a quick survey. Put up your hand if you've heard of the Toronto Charter. Less than half of the room. Thank you. Okay, we need to be able to stand before you in a year or two's time and have all the hands go up, because we want you all to know about the Toronto Charter. The Toronto Charter is an action plan for how to deal with HIV and AIDS within Indigenous communities. It was developed in consultation with Indigenous peoples and communities in Australia, New Zealand, Canada, and the United States, with significant input from people in Latin America. It provides a call to action of communities, health agencies, and governments to provide appropriate and timely responses to the ever-increasing rates of HIV within our communities. And if you look closely, you can see a few familiar faces there. In Australia, we have an organisation called Anukunna, the Aboriginal and Torres Strait Islander HIV/AIDS Alliance. It was recently established within the last 5 years, and it has a large following of Aboriginal, Torres Strait Islander people throughout the whole of Australia. This organisation will play an important role at the next AIDS conference in Melbourne in 2014. In New Zealand, a recently established community-based organisation by the name of INA has been established, and its purpose and function is to improve the quality of life for people living with HIV and AIDS, to improve the quality of information on HIV given to our communities, and to advocate for the rights of all Indigenous peoples throughout New Zealand and further afield. In Canada, we have CAHR, the Canadian Aboriginal AIDS Network. I'd really like to acknowledge the work that they have done over the last few years, and the work that they've done in particular in bringing and developing international networks. CAHR is a national Aboriginal organisation and is committed to addressing the issues of HIV within a native context. Although the beliefs of Aboriginal people vary widely from region to region and from person to person, The agency has made a commitment to conduct its activities in a spirit of native wholeness and healing. This disease can only be overcome by respecting our differences and accentuating our unity of spirit and our strength. And I have to say that CAHR is leading the way in terms of building and developing community-based strength and resources in response to the increasing rates of HIV. The International Indigenous Working Group on HIV and AIDS recently produced their first strategic plan on HIV and AIDS. This international group brings together people from New Zealand, Australia, the United States, Canada, from several countries in Latin America, from Mexico, and further afield. And the international group is in its early stages of development, but the intention is to grow and develop, and we are already seeing that happening. This international strategic plan is currently being evaluated, and you can expect to see the results of that within a short period of time. So, how do we know that these community-based organisations are really making a difference? Well, these are some of the indicators of success. Many of these organisations are led by positive people, by HIV-positive people showing strong leadership roles, and this is leading to significant community support. We're also seeing significant amounts of community and policy engagement, especially here in Canada, and that is certainly to be encouraged, and that over time will make a significant difference, I believe, in terms of bringing down the rates of HIV within Indigenous communities. We're also seeing significant amounts of community development and capacity building through the development and the implementation of strategies within these organisations. People are gaining significant expertise and experience in how to develop programs and how to develop appropriate programs and how to contribute towards the communities in which they work. We're seeing the development, we're seeing an increased awareness right across the board and in our communities of the impact of HIV and what we need to do to prevent the transmission, but also to support people with HIV and certainly the families who are affected by HIV. We're seeing the development now of culturally appropriate health promotion packages, and we're also seeing the building and development of strong international networks that will continue to thrive and grow. We're seeing an enhanced presence of Indigenous people at international meetings. In 2006 was really the first time when we had a specific track dedicated to Indigenous health issues. And when you think that the first AIDS conference was held, well, there were 15 AIDS conferences before that, which was the 16th. So the first for 15 AIDS conferences, Indigenous issues never got addressed. They focused on the 4 H's and forgot about the next letter in the alphabet. It was very timely to see that addressed here in Canada, and the credit really must go to the Indigenous communities of this country for ensuring that we got onto the program. And since that 2006 conference, there has been significant input at international meetings, and you can be absolutely sure that when you come to Australia, to Melbourne in 2014, that there will be a very, very strong Indigenous presence. It's at these international meetings that our issues get talked about, they get put on the agenda, they're brought to people's attention, and that's when we're going to see real leverage happening, and I believe it will have an impact back in the countries from which we all come. We're seeing significant cross-country collaborations, and I need to acknowledge the important work that was done by the CAHR and the equivalent bodies in New Zealand, the Health Research Council, and Australia, the National Health and Medical Research Council. Those 3 funding bodies got together and developed a tripartite collaborate research funding stream that has recently been confirmed and will continue into the future. But I can tell you from my own personal experience that has generated significant momentum within Indigenous communities and Indigenous research networks in Australia, New Zealand and Canada. And I would hope that that continues into the future. And yes, there has also been important amounts of government funding and contractual agreements but as many people in this room would agree, and we had that message confirmed last evening by our speaker, we need more money. We need more money, and it needs to be ongoing, and it needs to continue, and it needs to come from all the countries who have significant Indigenous populations. So the future, what does that hold for us? Well, we need to have a holistic approach to health that acknowledges the role of family and communities. We need to understand and recognise the dual impact of multi-morbid chronic illnesses and the ageing population. Many of you here will realise and understand that we are faced with an even greater epidemic, the epidemic of chronic illnesses, and the World Health Organization recently put out a publication saying that there's going to be a tsunami of chronic conditions that will affect developing and developed countries right around the world. Well, for Indigenous peoples, it's going to be not only a tsunami, but also a train wreck. And it's coming at us, and it's not very far away. And knowing what we know about health disparities within Indigenous communities, we can be absolutely sure that Indigenous communities are going to bear the brunt of this impending epidemic. And HIV is going to have to be dealt with as one of the many chronic conditions that we are confronting and we are living with, especially as we grow older. We have an ageing population, and we are all going to be adversely affected by the multi-morbid chronic illnesses, of which HIV is going to be one. We need to see an enhanced access to HIV services, especially testing and support. And if we know that Indigenous people are more likely to test late, this has major ramifications in terms of ensuring that people have ready and regular and timely access to appropriate testing. There needs to be collaboration between communities and policymakers, and we need to see the building of Indigenous leadership, and that involves everybody affected by this particular, by HIV and by the epidemic that we're going to be seeing in the short term. Communities and politicians need to work together, and politicians need to listen to communities. We need to recognise that the top-down approaches to HIV do not work. And in fact, on current indicators, they seem to do more harm than good. We need a bottom-up approach that recognises the vital role that communities play in leading the fight against HIV. But most of all, we need to recognise that Indigenous peoples are remarkably resilient. We have been affected by the onslaught of diseases and epidemics since the arrival of the coloniser. HIV is just the latest. We must draw on our innate resilience and our community strengths to overcome HIV. And finally, I want to acknowledge the tremendous work of our rangatahi, or our young people, especially those working in HIV and sexual health. You are our future, and you are the ones who will have to pick up the torch and carry on the struggle. But I have great confidence that you will do this, and I truly believe that we can look forward to a world without HIV, a world where Indigenous peoples will no longer suffer from HIV disparities. I was struck last night by the number of people in this room who were born after 1980. Maybe you could put your hands up again. Oh, they've all gone away and worked today. I was even more struck actually by the fact that most of them were sitting down the back of the room. And those of you who looked round will remember that. Well, I'm saying to you people, it's time for you to come forward and take up your rightful positions, and for the old ones like me, who were sitting at the front of the room, to move aside and make room for you. And I can't help noticing that we've got lots of empty chairs up the front here this morning. So let me say to you that I believe that we can overcome this epidemic, that we can make a difference in the Indigenous communities from which we come, to which we belong, but also we need to remember that we're all in this together, Indigenous and non-Indigenous. And as Dr. Montana said last night, this is no way to treat your friends. We all need to work together to make a difference and overcome this epidemic. If there are people living in our community who are suffering more than others, there's something wrong. I don't want to live with it, and I believe that everybody in this room does not really feel comfortable knowing that we have neighbours, that you have friends, that you have fellow citizens who are adversely impacted by this epidemic. It's time to do something about it, and we need to do it now, and it needs to begin today. We can do it if we work together. Let's start on that mission. Megwich, kia ora, thank you, and merci beaucoup.
There you go. We'll wait. So we were able to take a few questions. I know there are some folks with microphones, so if you would like a microphone and like to ask a question, just, raise your hand like this young lady.
I'm not so young. Thanks for the young lady. My name's Louise Binder, and I'm with the International Community of Women Living with HIV/AIDS. First of all, I'd like to thank you very much for that elegant presentation. I'd just like to suggest, if I may, respectfully, a couple of additions to the comments that you've made, particularly in relation to women and intersections of issues for women. One that we are very aware of internationally is the concurrent epidemic of violence against women that's taking place around the world. And it's two-pronged. It's intimate partner violence, and it's also structural healthcare worker violence. And I would strongly suggest that it's probably having an additional adverse impact even more profoundly in the Aboriginal communities, Indigenous communities. Second, we're also noticing an intersection in the lack of women's ability to manage their sexual rights and health, which is also impacting this epidemic. And the third thing I'd like to suggest to you is that you spoke about testing, and I think that the ongoing impact of stigma and discrimination, and in Canada, we have the dubious honor of having criminalized more HIV-positive people for non-disclosure sexual activity than any other country, is actually going to lead to the no test, no arrest kind of approach. And that, I think, is a profoundly burgeoning problem for us. And I think it will be, particularly given that Indigenous people are so overrepresented in our prison populations. So I think perhaps those are things we could kind of add to your already long and difficult list.
Thank you, Louise. First of all, I'd like to apologise for not joining up. I understand we had a date last night, and I somehow missed it. I didn't get there, but I also want to acknowledge you and the wonderful speech you gave in Washington. I didn't think I'd be standing here being questioned by you, by this remarkable person who stood up on the stage and kept Bill Clinton waiting. But I was one of the people in the audience shouting for you to continue. I totally agree with all the points that you made. I think we've been seeing significant changes in the course of the epidemic. That's undeniable. And especially in the country from which I come, sometimes we overlook the factors that impact upon women in particular. And I acknowledge that we have significant issues with regard to violence within Indigenous communities. We also have significant issues with regard to translateral violence among ourselves, and we also continue to deal on a daily basis with the impacts of colonisation. And I think it's fair to say, and I'm sure George Orwell wouldn't mind me misquoting him, but all of us have been colonised, but some have been colonised more than others. And I think it's the impact of colonisation within our own communities and the extent to which some people are so heavily colonised that they express their negative behaviour towards one another within our own communities, and how we deal with that and how we grow and work and develop as communities, understanding the role that each of us has within those communities is going to be integral to developing and building effective leadership. I think in the early days of the epidemic, many of our Indigenous leaders didn't want to know about HIV. It was a gay men's issue. Now it's become a women's issue. They still don't want to know about it. We need to educate them, bring them on board, and we need to get them to be able to develop and grow inclusive societies where nobody's discriminated against, where stigma is a thing of the past. But it's taken a long time, but I'm hopeful that we're going to see change as we continue fighting against this epidemic. Any more questions?
My name's Andrew Beckerman. I'm the chair of AIDS Vancouver Island. I had occasion to speak with my MLA last week, and we both agreed that I do wonderful work, my organization does wonderful work, we have wonderful volunteers in the community. But when all is said and done, the work we are doing at present is really band-aiding over a failed society. And until we are willing to address the core inequities, the basic social injustices of which your talk this morning shone a light certainly on a number of them, all we do is band-aid until we have greater income equality, greater access to everybody to housing and food and medical care. We keep seeing the same clients with the same problems, and until we have a basic rejigging of our society as well as societies around the world, I'm not sure that we can make as much progress as we have the potential to make.
Thank you. When I began my training in public health, the very first message I was given was that if one sector of the community is disenfranchised and marginalised and oppressed, then the whole of our community suffers. So if we can improve the plight of the most marginalised, of the most oppressed, of the most discriminated against, we all benefit. And I totally agree with you. We tend to apply a band-aid rather than addressing the structural issues. And our speaker last night, Laverne, talked about the importance of social determinants of health. To get governments to address those issues is a major, major challenge. And how we do that, I'm not quite sure. But until such time as that happens, we're going to continue to see difficulties, barriers, and challenges as we try to address the impact of HIV on the most marginalised groups within our community. However, at the same time, I think we've got a lot to learn from people on the margins, and we need to keep our eyes open and our ears wider open in order to understand what those messages are and how we can apply those to the wider community.